Welcome, everyone. We're really delighted to have you here for this event on turning commitment to action for mental health. At Wellcome, we are here to support science to solve the urgent health challenges that are facing everyone. And we believe that we're on the cusp of a revolution in mental health. We believe that this is going to spark a new wave of interventions that both mean that we can intervene earlier in the course of someone's mental health condition, but that also that we'll have better options for the nearly 1 billion people who are living with mental health conditions around the world. We're really proud to be the largest non-governmental funder of mental health research globally. And we believe that evidence is absolutely essential for us to be able to make that step change in early intervention and to improve lives. This event is coming at a really crucial moment for mental health. We've just come away from the UN General Assembly, where the high-level meeting was the first moment that mental health has been recognised on the UN General Assembly agenda. The mental health sector worked really hard to secure commitments there to make sure that the political declaration, which is nearly over the line, will close the treatment gap for mental health. And that's going to mean that nearly 150 million more people have access to the effective treatments that they need to, and in a way that's informed both by evidence and by lived experience. Overall, we know the declaration fell short for many in the NCD community. It wasn't where they would like it to be. But from Wellcome's perspective, and in terms of mental health, we're really pleased to see the commitments there to scale up the treatments that we need for depression, for anxiety, and for psychosis, and particularly at a primary care level. It was really encouraging to see that decision makers were thinking about mental health within that broader context, recognizing the need to integrate it into a broader conversation about health, and to be ensuring that we're considering the other factors that affect mental health, so economic, educational, and social systems. Today, we want to continue in that vein. We have speakers from a wide range of sectors, but who all share that passion for and commitment to mental health. But before we get going, I want to hear from some of you around the room. We're very conscious that this is the only event on mental health that headlines mental health here at WHS this year. So I would love to see of you who is here predominantly a mental health role, a mental health adjacent role, or just because you care or you're interested about this issue. So first, who here works in a role that's directly related to mental health? Oh, quite a few. And a role adjacent to mental health? Not so many. That's a number I think we'd like to see go up. And finally, who's here because you're interested, you're passionate, you care about mental health? Well, wonderful. I think that's everybody else, I hope. So we want to make the most of your time and your interaction today. We have a Slido where you'll be able to put in your questions. So please use the QR codes up here on the screen, or you can use the type in the number that you see there, 5141555. Please do put your questions in, and we'll try and take as many of them from the floor as we can. Our first section of this discussion this morning is going to focus on global priorities for mental health, and I'm delighted to have three speakers here with me. I'm going to ask them all to introduce themselves as we dive into the discussion. So, let's crack straight on. I'm going to come to Mark first. Mark, tell us first, just briefly, who you are, what's your role, and how does mental health appear in that?
My name is Mark van Ommeren. I work for WHO, and I lead the mental health unit, soon to be called the Mental Health and Substance Use Unit at WHO. So mental health is obviously central to that. I have background in statistics, psychology, and epidemiology, and did a lot of field work on building back better mental health systems after emergencies. And I'm really passionate about mental health because I see the suffering around the people I love. That's why I do this work.
And so you're the perfect person to start by telling us that the billion people who are living around the world with mental health disorders, your atlas tells us the scale of the problem. Please tell us more about what's the state of mental health globally. What do we know now?
Well, with the billion number already indicates that this is extremely common conditions, and as was in the launch 2 days ago of the global burden of disease, showing that the rates are going up, particularly among young people. We in the atlas, it really highlights, kind of disappointingly, that the investments are not increasing as a correlate to the increasing political commitments, which there is more political commitment, and investment usually lags, but the investment is not there yet. And as a result, what's the real reality for people who suffer is that, for example, for psychosis, in the average year, and in the last year, only 29% of people with psychosis were in care. This is the most severe, most impairing of all health conditions, is schizophrenia. Only 29% of people around the world were in care, 71% in high-income countries, so most, but still, 30% people with psychosis in high-income countries, not in care. And in low-income countries, 2%. And for depression, the numbers are even much lower. And I can tell you more about that if you wish.
Go on, build on that.
Yeah. So we know for minimum acceptable care, which we define as either having a number session of talking therapy or antidepressants for depression. Minimum acceptable care for depression is even high-income countries, it's only 1 in 4. And in low-income countries, 3%. So these are daunting numbers, partly because, again, the investment is relatively low and the prevalence is very high. So we struggle. We also struggle with not only with the rates of disorders, but also on the perspective of rights. Half of all the hospitalizations for mental health in the previous year were involuntarily. That's way too high, way too high. And in mental hospitals, 1 in 5 are there longer than 1 year. That is absolutely wrong. Should be exceptional, if ever, that it's that long. So we have, on the rights part, we have huge issues. On the resources, we have huge issues. But as I hope we will show in this session, there's also many opportunities, and there's ways to address these daunting numbers.
Yeah, so you've painted a difficult picture for us of the challenges we're presented with. I know Mark at WHO and at Wellcome, we really care about the evidence base and the evidence that we have that tells us about what works. So give us some of that optimism now. What evidence do we have about what we can do at this kind of scale to make a difference?
Well, for many people not working in mental health don't realize, and who are like evidence, don't realize that the first NICE guideline was, for example, on schizophrenia. So mental health is a field with very strong history of science and evidence. And for most mental health interventions, we have effective interventions. Not very effective interventions, they are not vaccines, but there are interventions that work. And but what we see in globally is, of course, when public health leaders say, mental health, I want to invest in mental health and primary health care. And then you see too often, I don't want to be too critical for the colleagues working so hard, a very superficial effort of integrating mental health and primary health care. And it washes out because there's not enough investment. So we know that these interventions, they need to be supported. You need to decentralize specialist services to the districts or so people get the support. So there's a lot to work on the health system to actually get these things working. And then beyond primary health care, there's a really huge uptake on evidence for psychological interventions and making them scalable, either by task shifting, by having non-specialists do this, or through digital means. Wonderful, but again, they need to be available and they need to be made available so that people know about them and people know which ones are effective and which ones aren't. People get access to the effective ones, not to the smoky ones. So there is again a lot of health systems work to be done to how are we going to make sure that these interventions reach people? How much, if there's a good digital program for mental health, and there's quite a few of them, how much guidance do people need to use them? There's a lot of questions to be answered there.
Lots of questions, but you've given us some hope and given us that within the global context. Dr. Mohammed, can I come to you for a regional perspective on this? Because you have a strong background in this area as a practicing psychiatrist. And now your role at Africa CDC really puts this at the heart of it. So what are the challenges that you're facing on the continent in terms of mental health? I think it's okay.
Okay, yeah, really, thank you so much. Like you say, my name is Mohammed. I used to work in Nigeria as a psychiatrist. Now I work in public health at the Africa CDC, where I lead the Division of Disease Control and Prevention as the head of that division. That division has mental health as one of its core activities. Going through all of this, one of the most important thing that struck me, and looking at some of the challenges that Mark has spoke about, is that in mental health, over the years, we have tried to apply clinical methods to what is essentially a public health problem. I will go a little bit further than that. It is essentially a whole of society, a whole of government approach that is required to take care of some of these challenges. At the UN, we had so much political commitment, and it now lies on people like us to see what can we do to move from political commitment to action on ground. And I dare say this goes through a lot of advocacy. So we need to build advocacy. To give a little bit more meat to what I'm talking about, we in Africa, Mark talked about 29% for people with psychosis not getting help. In Africa, it could be as low as 5% of people with psychosis, schizophrenia, having access to help. And what traditionally we've been doing is to put more money in big government hospitals, train more psychiatrists, and that's it's good intention, but it does not use the other aspect of the health system that could be more impactful. And that is why when we hear at the UN General Assembly the emphasis on strengthening the health system at the PHC, that is a good thing and move in the right direction. So what next do we need to do? We need to show, like you asked, Mark, the evidence that shows that intervening at the PHC can bring results. We've seen it with other programs. If you ask a HIV program manager, he knows every single thing about what he's doing at the PHC. We need to have equivalents like that. The vertical programs in Africa, which is now coming down because of the reduction in funding, we need to now see how we realign, imagine the health system at the PHC to go more from vertical to being horizontal. And I think mental health is going to learn a lot, gain a lot from how to this horizontal alignment in this. But I want to come back to something that is very important for Africa, and Mark talked about it, where we have a very high degree of people with involuntary retention in mental health system. That in Africa, it's even worse because there are a lot of human rights abuses, and that goes down to the fact that we still operate some of the most archaic and old mental health laws in Africa. Some of them dating back to the time of colonialism, using pejorative terms and encouraging human rights abuses. We in Africa are working assiduously to see how this will change, because you cannot practice mental health when you are backed by a law that allows abuses and mistrust of the system by those who are going to consume it. We are obviously also learning that to make mental health strategies and laws, we need people who are insiders, who have been part of that program, people with lived experience, who will be able to guide to ensure that the programs and the policies we are bringing up speaks to the needs of those who are using it. So these are some of the things. I'm going to come back later to, if we have time, to the financing component, which is very key. People talk about it all the time, but we in Africa CDC, we have a way that we are thinking about this financing. If we have time, I will come back to it. Thank you.
Great. I'm going to pick you up on that. Dion, tell us about your role, why you're here, and then I'll launch into a question.
Sure thing. I'm Dion Ras. I am an advisor to the Global Mental Health Action Network, which is one of the, if not the largest network focused on global mental health advocacy, with over 7,000 members from 170 countries. It's very lovely to see a lot of passionate or I guess, kindred spirits here that are also very much passionate about mental health.
So, you were really involved in the high-level meeting recently at UN General Assembly, the political declaration process. Tell us about your reflections from that. What did that mean to you, and what are your key takeaways from it?
I mean, to me, it was a very, I guess, promising and inspiring moment to be part of the process of drafting the political declaration, for being present at the multi-stakeholder hearing, and then also very much following the HLM, because it was really the first time that mental health was at the heart of a HLM. I mean, in the past, we kind of saw that mental health was at the sidelines. So, for example, in the third political declaration on NCDs drafted back in 2018, it was the first time that mental health was included, to my knowledge, in a political declaration on NCDs at all. But it left quite a lot to be desired, as I understood. And we kind of saw that many crucial topics were left either, I guess, not very much elaborated upon or left unmentioned entirely, which are like topics that we, I guess, as GMAN, as a community of 7,000 plus advocates, stand for. So things like, I mean, you already mentioned it, both of you, Mark, and achieving greater financial investment in mental health research and service development and into systems, scaling up, something I'm passionate about myself, scaling up community-based care. We also saw the mental health children and youth getting a lot more attention in the new political declaration, and then also suicide prevention and decriminalization. And so to just, I guess, zoom in on that example of suicide prevention. So, for example, to my knowledge, suicide or suicide prevention was not mentioned a single time, at least upon when I was looking at it. In the 2018 political declaration, it was only mentioned, I think, once during the Secretary General's speech in 2018, at least if the prepared for delivery version was as accurate to how the speech was shared in person during the HLM. In fact, mental health wasn't even a part of the title of the 2018 declaration. Children were mentioned with little elaboration. There was no explicit mention of youth as a group separate to children, in spite of the fact that we all very much know and have known for a long time that development doesn't end when you're 18, of course. There was no mention of community-based care, despite its effectiveness in supplementing and supporting existing care structures. And to move on from, I guess, this somewhat negative picture I'm painting, to now the new 2025 political declaration, we saw that mental health is not only part of the title, but more importantly, it's no longer on the sidelines of the drafting process. So from the beginning, governments convened to discuss mental health as a priority. And you can really see this in a manner of ways, not only in terms of the document, but also in terms of the sentiments and the emotions around the room at the event itself. So just, I guess, to first start with the document, it now includes under its commitments comprehensive sections on suicide prevention and decriminalization. We saw integrated mental health care. We saw scaling up community-based care. We saw the involvement of people with lived experience, which is a very important thing and close to my heart as well. And the scaling up and mobilizing of national and financial resources for mental health care, among others. And then to kind of go to the room aspect of it all, like what were the sentiments and how do people feel in the room? We really saw that so many countries were being very supportive of mental health as a priority. We saw that in their statements. We saw a lot of impassioned speeches filled with lived experiences and people sharing really I guess, sharing like very deep and personal and candid experiences. And we also saw a lot of NGOs cheering one another on in what culminated in a very, I guess, beautiful and powerful moment and even more powerful message, which is one that quality mental health and mental health care is really central to achieving universal health coverage and the goals set out in the agenda for the sustainable development.
Oh, thank you. It's great to have that picture you paint from 2018 to where we are now and the sense of commitment in the room. And of course, we do need to turn the words into action, as all of you have said in different ways. So I'd like to come back to Dr. Mohammed on this point on financing, because we know sometimes things are free or cheap, but often they take money. So tell us about how can we pay for this?
Yeah, really, that's at the core of what we're discussing in Africa. We've seen that there has been a sharp drop in development aid to health in Africa. And the anxiety among the mental health community in Africa is that some of the shortfall for the infectious diseases will come from NCDs and mental health a budget that is already inadequate. So one of the things that is critical to ensuring that we increase financing to mental health is evidence generation. And the process of generating evidence, like the DG of WHO, Janabi, said in yesterday's event, it's not by piloting. It is by using whole of government data. How do we ensure data coming from hospitals, coming from surveillance, gets to where the decisions are being taken, so that people understand the consequences of not doing anything and the consequences of allowing untreated depression in a woman in a village in northern Nigeria, for instance. So these are some of the things Africa CDC is really working on now. Through some of the programs we're doing, we are training FETP people that can be able to look at strengthen the evidence generation in their member state. Some of them are already going back to the member state to support the surveillance system for mental health, surveillance system for psychosis, and childhood depression and cerebral seizure disorder, for instance. So again, for all of us staying here, working in a situation like in Africa, you have to look for where the financing for mental health is fragmented. You see some in different ministries, but the ones that we pay attention to most often is the one in the Ministry of Health. I'm telling you that if you go to the Ministry of Women Affairs, some Ministry of Women Affairs have budget for mental health activities. Same in the Ministry of Education, same in different aspects. So what I'm saying is that we also need to look at it from the multi-sectorial action and coordination process to ensure that other people who are close to health also budget some of their reason for their concerns. In the Ministry of Communication, for instance, there will be some funding for communication activities that is held. The Ministry of Women and Gender, education. So all what we need to do is to bring all of these budgets under our purview, they exist, and send people who can meaningfully use this budget for the right action. And that is why Africa CDC is building a committee of advocates through a short course we're running. When you said people should raise hand here, I was expecting to see more advocates for mental health, but we didn't see. We are changing that on the continent of Africa because we believe that when we build political advocates and advocacy in extra health department, then we can increase funding for mental health. Thank you.
Thank you. This cross-sectoral approach that we need to deal with the issue of mental health, I think, has come out through all of your comments in different ways. I want to pick up on one of the questions that has come in through Slido, because all of you in different ways have touched on the research agenda and the evidence. And someone here has asked about, when we talk about evidence-based practices, most of the research and plenty of the interventions are Western-centric, with an immense focus on white men in clinical trials, and that results in barriers to care in marginalised or other communities. So I'd love actually for each of you to give a perspective on that from your side. We know the equity issues in trials and in research in general. So what does that mean in mental health, and do you have thoughts on how we can overcome it?
Well, this is a hugely important topic and very concerning in 2025, where there's a lot of pulling back on work on inclusivity, the whole DEI discussion that is politically in many countries. So I think it's a disaster. We know very well from many areas of health that the evidence from one gender doesn't necessarily generalize the other gender. There is chances that some of the work, some of the interventions do not generalize across countries and cultures. In general, many mental health interventions evidence does generalize, but one cannot presume it. So one has to test it, not in every single country of the world to replicate everything 150 times, but some replication is absolutely necessary. And but the concern is that there's a big pullback on this, and which is something we need to be alert on.
Yeah, really, thank you, Mark. This question, and I really thank the person who asked this question. It's very important for Africa, because one of the problems we face is that most of the data generated from research are outside of Africa. And when recently we reviewed the work we were doing last year and part of this year, we decided going forward we need to change that. One of the programs that we're hoping we can bring forward is a workforce development program that will focus on strengthening the capacity of our member states to have people who can carry out both primary and operational research. That's a PhD in global mental health within the continent, not in Europe or America, and a kind of research exchange that will allow some of these activities to take place in Africa. And what are we seeing? Of course, there are a lot of similarities across, but mental health is about behavior, it's about a lot of psychological realm, which differs between continents, and the way we feel, the cultural component and all of that, which means that we need to check the sciences in different cultural setting, in different psychological and physical setting, and that will also encourage people to accept that the interventions coming from these things is workable. If you look at the MH gap, for instance, there have been a lot of implementation work in different parts. But when we go and we talk to our ministers of health, they want to see what is being done, and whether it is the same intervention is useful in Africa as it has been shown to be useful in different parts of the world. And for me, I've seen that it is useful, but we need just to be able to package it in a way that these policymakers will understand, and we get the message that these mental health interventions work.
Thank you. Putting it all back into everything into its local context. Dion?
I don't think I could put the gender part of I guess, inequity when it comes to interventions and how they're developed. I don't think I could put it better than you, Mark. Definitely the, I guess, data from men absolutely does not generalize in all cases to women. I guess what I can speak about, though, in relation to the question, is more so a lived experience perspective in terms of that there is also quite a lot of inequity, or I guess a pervading belief out there that children and youth are the same kind of age group, I suppose, and that they need the same things, they have the same needs, the same wants, and that interventions directed at them should be the same, therefore. Naturally, that's not correct, but this is something I very much experienced myself when I voluntarily went to a psychiatric hospital, and I wasn't put in the same, I guess, unit, you would call it, as people of my age. I was 19 at the time. It wasn't people maybe, let's say 17 to 18 to maybe 21. It wasn't people of that age. It was people that were 40 to 50 plus and had, in their words, been there for a very, very long time. So maybe 3 to 4 years. Naturally, that was very shocking to me. And that is, I guess, just one experience among so many other young people that so many other young people have told me about, that there is still a lot of inequity to tackle. Thankfully, it is now receiving a lot of attention in the field of transitional psychology and transitional psychiatry, which are looking at those exact age ranges of youth. So we're thinking let's say, people define it quite differently depending on the study and all of that. But let's say the ages of 18 to 25, it's receiving a lot more attention now. So I have some hope, but it is an issue that is not to be understated.
Thank you so much. I really appreciate you sharing that with us. It's so powerful to have the lived experience and the your personal experience as part of the discussion. And I think that actually is the perfect moment for us to pause on this section. I think we'll come back to lived experience as a theme. So I'm going to ask Mark to stay. Dr. Mohamed and Dion, you will come back to us later. Please can Jérôme and Lisa join us? Well, thank you. It's lovely to be joined by two new panel members here. Jérôme, I'm going to start with you, please. And please tell us about your role, what it means for mental health, and then I'll dive into a question.
All right, so I come here with two hats. The first one is that I'm Deputy Director for European International Affairs of the French social ministries, including Ministry of Health, but not only, Ministry of Labour, Ministry of Social Affairs, which is very interesting for the mental health issue. My second hat is that I'm coordinator of the European Joint Action to maximize the impact of the EU Global Health Strategy. And I will, for that reason, also address the regional approach, the multinational approach, and the interregional cooperation in mental health. That's going to be very important for the next months and next years to address this issue properly.
Well, thank you. And let's start with your national perspective, because your role in France means that you have a perspective on the year of mental health. And so please tell us about this issue in France, what that means for you, and why are you highlighting it as this national cause?
Yeah, as you know, probably our President Macron has decided to make 2025 a great national mental health cause. And I will explain why and how did it happen and why it was so important. First of all, it has been decided because we have reached a breaking point, really. Despite major reforms, the gap between the needs and the services was still growing. 1 in 5 citizens faces mental health distress in France. 1/3 of the young people declare being affected by mental health conditions. Yet, access to timely and coordinated care remain deeply unequal across regions, social groups, age groups. So we needed to do something. The COVID crisis already highlighted the fragility of the systems regarding mental health. And I invite you also to read the OECD report on mental health published a few days ago, very interesting, that confirmed that there is an underinvestment, but also a fragmentation in the system that continue to undermine prevention, workforce stability, and long-term outcomes. So by declaring mental health as one great national cause in France, that was not just symbolic and political, that was purely operational decision. What I want to illustrate this is that following an intersectional and inter-ministerial approach, it mobilized first our civil society, and the civil society was at the origin on the pressure on the politician and President Macron to obtain this. then all ministries, local authorities, research institutions, schools and employers around a shared commitment to treat mental health with the same seriousness, very important, funding, accountability, and as physical health. And I don't want to oppose physical and mental health because the great interest of mental health is that it is running in all health priorities we are discussing here at the World Health Summit. Infectious disease, human resource in health, they are also suffering from mental distress. Non-chronic or non-communicable disease, well, it runs everywhere. So when it will work for mental health, it will work for all health priorities in our systems. So the national cause has served a rallying network aligning communication, investment, innovation, and action under a collective ambition, prevention, inclusion, and parity or equity to implement mental health in all policies, not only all health policies or public health policies, but also all policies at large. We need to work with many, many stakeholders on these issues.
Oh, thank you. The intersectoralness of this issue, I think, has come out so strongly from all of you. I'm going to come back to you on the European approach, but before I do that, let me come to Lisa and ask Lisa to introduce herself to all of you and why is mental health important in your role?
Hi, good morning. My name is Lisa Indar. I'm the Executive Director of CAFA, which is the Caribbean Public Health Agency. We serve 26 countries in the Caribbean region. Why is mental health so important to us? I want to just take a step back about context and stigmatization. So we are small island developing states, and when you have when you have a threat like mental health, people see a phobia. It's all about that. Everybody knows your business, and everybody's afraid to say, well, I have a problem. So that's one of our biggest threats. But the situation is actually quite dire in the Caribbean. 1 in 4 persons actually face a mental health issue. And to top that off, 60% don't receive treatment. The treatment gap gets bigger depending on your social standing. And it gets worse when you think the type of issues we are facing. So we are seeing anxiety and depression, increase in suicidal rates. We are seeing among the youths that more and more persons, they're not just an increase in suicidal rate, but however, because of pressure, peer pressure and school pressures, we have had situations where after exams, persons, they thought, well, okay, they didn't do well, and they would have committed suicide. That was brought home to me from my son's friend when he said, well, Mom, my son committed suicide. I said, why? He says, well, he was afraid, to give his dad his exam results. The other thing that is happening too is that with all of this increased depression and anxiety, we're seeing also an increase or rise in crime and violence. So it's quite a hidden pandemic, but when you put it in the context of the Caribbean, being smaller island developing states, having different economic and social standing, and then you add the fact that because you're small, everybody knows what's happening. And then because we are small islands, we are also facing a lot of disasters. So when after a hurricane or earthquake or so on, you have that increased mental health threat. So the situation is dire.
And talk to us, because you see both the national and the regional within this. So how do you see those issues play out within your region?
Right. So the good thing is that, CAFA as a regional institution looks across the border and tries to reduce that stigmatization because of the fact that we're looking across the border. So we see a lot that is happening at country level, but I think leading the call from a regional level is important. So for instance, this year, where our Caribbean conference was the mental health, the hidden pandemic. And we were saying, it's okay. It's another public health threat. It's simple, like, you broke your foot, or you have, some other illness. It's simple like that, and we can get treatment. And it allows us to have a regionalization. So we are pushing regional initiatives. We know we have to focus on the youths. But it's not like an adult speaking to the youth. What we have been doing is training the youths to speak to the youths, institutionalizing hotlines where you can feel, it's safe to talk. So from a regional approach, it's really important, the policy, the advocacy level, the need for regional policy as well as national policies. And at the national levels, we also work individually with countries to say, what are the issues and how can we best address them at a national as well as a regional forefront.
Oh, thanks. It's really great to see how that fits together and you get the synergy then between countries, between regions.
And as a regional entity, what CARFA will bring is the whole networking with all the different agencies. So the UNICEF and the governments and all the Red Cross and others, we would bring that, to work together in the region as well as with the countries.
So a powerful alignment of the actors. So flying us from the Caribbean back to Europe. Jérôme, tell us about the European joint action. What does that really mean?
Maybe first, I would like to explain how a political impulse, as long as it is followed by a very concrete implementation plan, a roadmap, and I was very happy to go to Qatar and Doha for the Ministerial Summit on Mental Health, because that was a few days after New York and the HLM declaration on NCDs and mental health, to see that we were already discussing implementation plan and moving from declaration to action. So in France, in few months, this decision to make 2025 the National Mental Health Great Cause has provoked rapid change, very interesting change, because there was a roadmap built. The first change has been both structural and cultural. First, we are integrating mental health into primary care. It's extremely important through early detection, multidisciplinary community teams, and digital tools that connect patients, professionals, and social services. Social services have also their room in this landscape and are very important. Second, we have strengthened promotion and prevention, starting in schools, universities, and workplaces. The role of employers is also very important. We spend major part of our life at work. So what do we do for mental health at work? What do we do to reintegrate, to rehabilitate also mental health patients in the labor market? Rehabilitation is key. So with public campaign to reduce stigma and increase mental health literacy as well, and with mental health first aid training was also important. And third, we are investing in data and evaluation. Evaluation is key of our measures, of our tools, guided by evidence and outcome measurement. And this is a major step forward for transparency and accountability in our measures. So regarding the regional level, very important also, because there are, of course, inequities, and we do not stand at the same level in these reforms and measures, but we are ready to share experience, taking into account also regional specificities, health determinants in other countries that are not the same than in our countries. So the dialogue between countries to bridge the gaps in these inequities is extremely important between countries, but also to propose to exchange evidence-based good practices validated in one region with other region, for instance, with Africa CDC or with Latin America and other regions of the world. Very important, the European project, because it's a regional approach, not in the sense that there will be top to bottom recommendations soon, but because it allows bottom-up exchange of good practices and find people that have the same environment and same health determinant as you to exchange good practice.
Well, there's lots in here that I want to explore, because I think many of us who come to lots of these events are very used to grand political declarations and lots of words, but actually what you're talking about, very practical operationalization, is really inspiring, I find, actually. But this idea also of learning between regions and both making things specific to context, but also how you learn from others, I think is really interesting. So Lisa, I wanted actually to come back to you on how do you learn within the region or between other regions about what works, what's effective, and what voices can you bring into that?
Yeah, so that's a good question. And being a regional public health agency, I say we have a comparative advantage because we're here. We're learning from our international partners. We're learning from the Global Forum. And, you know, yesterday I was saying, I think I was privileged because I get to be in a global forum, but many of my colleagues can't do that. So my job is to make sure I take back what my lessons learned back to the countries or to the individuals. And, you know, one of the ways CAFA works is boots on the ground. We hold your hands. Because we're in the Caribbean and we know the region and we know the persons, we work with them. And to be honest, I'm really glad what my colleague is talking about, the interventions. So things that he is speaking about, advocacy, policy, legislation, those are all the things that we are advocating for at the highest level. Putting mental health into school-based programs, some of the same things, integrating it into primary care, you know, treatment and having more first-line persons to treat mental care and all that. Mental health is important. But one of the things that we have taken the approach is getting down to the issues. And the issues are that people still feel that stigma. How do we move from that stigma to say, okay, it is okay to feel a bit anxious or, you know, being depressed today doesn't mean you have to be depressed for the rest of your lives. And it's okay to maybe probably have a suicidal thoughts, but you can overcome that. And so that bigger approach, targeting the youths or having targeted interventions for women, for youths, for older people, depending on what they are facing, is what's really, really working for us. So we take the regional approach, we work with the countries to see how we can do that. Then we learn from the countries too. So Barbados have a teen program. Last year there was 6,500 calls to a small country like that in a teen program. So we thought, well, this is working. And a lot of them were, okay, I'm struggling with substance abuse. So now it's taking that and now developing programs for that. In Trinidad, we gave a mental health day after COVID because you got, you know, I remember for COVID, we were working, especially people in public care, first line responders, we were working 15 hours a day. So you were stressed mentally, and then everybody was afraid to say, well, you know, I'm so tired. So after a while, you know, when you know, after 2 years, we said, okay, take a day off, just breathe. Do not, I've said to persons, do not get on their emails. Just take a day off. So it's that context as an intervention, learning from the countries, learning what's happening here globally, and then applying it.
Well, thank you. And Mark, you've waited very patiently here. Tell us about WHO's role in this, because learning and that's the sense of creating a shared evidence base is really critical to this. So what do you see as the important foundations there?
Well, I see WHO's role very much of helping to transfer the knowledge that's generated. I'm sorry. I very much see WHO's role as key to transferring the knowledge that's generated by researchers, perhaps funded by Wellcome, to have to make sure that to synthesize the evidence and then give the policy options that are most effective to decision makers. Because there is there's so many publications out there, so much studies in mental health. It's overwhelming. So the evidence synthesis and the conversions into guidelines is one of our key roles at more at the global level. In the country level, we talk to ministries of health, and you do surveys. But who do they read? Whose information do they trust? Whose support do they trust for just advice? It is WHO. So there we play key roles And we are often invited to support countries in the policy and legislation processes. And they need to be evidence-based, but also rights-based, involving people with lived experience. And they need to have the content that's really going to make a difference.
I'm going to start picking up some questions from the Slido now, and thank you for everyone who's putting these in here. We have a few on this theme of political commitment and turning it into action. So actually, first one for Jérôme, I think in particular. France is assuming the G7 presidency later this year. Do you see any opportunities there for France to champion mental health as part of that?
Well, indeed, our approach for the G7 will be to try to put health in all policies. And I think this pretty much relates, if I have a recommendation to make to WHO, if I may, because you are involved also in the UN broad discussion, UN 80, UN 2.0 discussion. In France, this experience of the national great cause, 2025, we learned three things. But first of all, it's very important to make mental health everyone's business by a whole of government, but also a whole of society approach. We have broken silos: health, education, agriculture, labor, justice, housing, culture, and the digital sector were involved in this roadmap and approach. And I think at UN level, WHO, with its expertise, with the data that you will collect also and evidence, you should influence the other UN organization, ILO, for instance, OECD, many others, to include mental health as a solution, as also a preparation to future crises, bridging the gap with what they call the global or mega trends, security, defense, competitiveness, etc. So very important that you develop this dialogue. Then invest early and measure consistently. That's very important. Measuring indicators, evidence-based data, whether through school-based programs or digital self-care tools. For instance, intervention are assessed for impact and cost effectiveness in line with OECD recommendation. And finally, co-produce with people with lived experience is essential. It's very important. And this is really the most transformative shift we have observed in France. We know systematically include service users and families in the design, evaluation, and governance of our policies, ensuring they are not subjects of care, but partners of change. Thank you.
Well, thank you. Such a powerful message on lived experience coming through from all of you. There is a question here about how we hold decision makers to account for high-level commitments. And I think if I read this question right, it's to not just for the commitments themselves, but how we do turn them into action. So I wonder, can you give us a perspective on that, Lisa?
That's a hard one. It's easy to put, I want to say it's easier to put legislation. The harder thing is to enact them. And so from where I sit, you're dealing with 26 countries, and everyone comes to a forum and say yes. Yeah, we have that all the time. And then the hardest thing is, but you made this commitment, So part of it is a call to action where we do the follow-up. So at the 69th, we had, sometimes you have to go big and bold, and call out. So when we had the 69th year, the 69th conference, mental health, the hidden pandemic, we invited the ministers and so on. We invited them up on the stage, call to action, and we invited them to develop a plan of action, and that is the follow-up. Taking the lessons learned globally and applying to context, the WHO international standards, learning from what works is important. We could say these are the things that work, but let's apply it to the Caribbean context, because that was an issue before. What is the Caribbean context? We know that youths have a bigger, it may seem to be a bigger problem. We know about the stigmatization. So putting measures in place, not just the legislation and the advocacy and so on, but calling them to action is important. And that's how I think we have been making advances. If you call to action too, there will be funding. So we have had some interesting advances. We have about 11 countries putting mental health as part of their policies, integrating it as part of their primary care, as well as emergency response. So when there's an outbreak or something like that, actually now you have a couple of countries, not as much as we would like, but you have a nurse or a psychiatrist at emergency care. So, because that might be the bigger problem, not just the fact that your hand you had a bruise. So those are the things. But it's not an easy thing, to be honest. And you have to constantly work at it and ask persons to be accountable for what they said.
It's a difficult question, I think, for both of you to answer, but you've also touched on data and the importance of tracking commitments and progress. So I wonder if both of you have a view on that, or if there's more you want to share on how do we hold our leaders accountable for this?
Well, I think this is where we're so happy that there is a increasingly active, very active civil society movement, because I think it's the bottom up. That's where the voters are. I remember years ago in Uganda, a certain mental regional clinic didn't have medicines, and people of lived experience organized themselves. Service users was the term at that time. They organized themselves, and they protested, and they got the medicines a lot quicker than the local specialists were asking. They didn't get that. So there is a power to bottom up advocacy. And on the other hand, for example, for suicide prevention, we focus a lot on reducing suicide from acutely toxic, highly hazardous pesticides. It's the quickest way to reduce suicide rate in countries where that's a common means of suicide. And with data, with monitoring, what pesticides are there, what are the means people use for suicide, it's extremely powerful to hold to have the discussion with pesticide regulators and change the law. And if you want to see graphs where suicide rates have dropped over time, and you see it's always in relation to, a change of regulation on means of suicide, like dropping of pesticides, paracetamol in bottles rather than in strips, changing of the way cooking gas in the UK, etc. So this is super important, and data is the way to go.
So my best recommendation is do not build any national roadmap plan without measurable actions. So measurable actions mean that you will collect data, and these data are really essential to develop the dialogue with other sectors and ministries that are not very aware, that lack literacy in mental health. So that's key to provide this evidence, because as Ministry of Health, as WHO, we are representing science, and we are representing evidence-based data and arguments. So when we implemented different measures in France this year, like Mon Soutien Psy, which is a 10 free consultation for any citizen that want to visit a psychiatrist or psychologist, or suicide prevention through the 3114 platform that you can call at any time, and the vigilance networks, etc. All these measures, including also the training and scaling up psychological skills among care workers or caregivers, and strengthening adolescent mental health services, all these measures were accompanying with measurement and collection of data. And based on that, we will see if these measures are efficient. We will adapt them if needed, and that's very important to develop this intersectorial dialogue.
Well, I think between the three of you, you've given us a very clear plan for action, actually, in terms of the voices that we need to bring into this, the lived experience, civil society, and having those powerful champions backed up by the data and then really measurable plans. I have one question to end on, because unusually for a session here, we haven't mentioned AI or digital tools after a whole hour. And we have a few questions about that in the chat. So one final question for this group on, there's people suggesting we can replace psychotherapy with AI, for example. and others asking about the role of digital technologies in mental health support. So I wonder, Mark, if you can offer some thoughts, and then I'll give the floor to the others before we switch.
I can discuss a lot and share with you all together. We can discuss the worries about AI and providing support, and they're there. But there's, of course, also opportunities. And if you think of the gap, like, for example, for depression, anxiety, that we're reaching so few people right now with evidence-based interventions. If we work very hard, maybe primary healthcare will add 5%. We share a lot of self-help materials with people, maybe another 5%. If we increase specialist service in a big way, maybe another 5%, we have 15%. And maybe with AI delivered support, maybe we have another 5%. So it can be helpful. But of course there are worries. There are great worries. And but I do not think that and this is all speculation, because a whole discussion about AI in the future is speculation, right? I think there are people out there who will be very happy with support for AI, and I think there are many, many people out there who will want a human being. So I think but most people right now not getting any evidence-based care. That's the context.
Thank you. That's very helpful.
Yeah, well, we cannot be blind on the fact that these apps and tools and services based on AI and digital solutions are numerous and developing. What we need is a framework to evaluate them scientifically, I mean, with experts and patients and people with lived experience of these tools. So framing a kind of network to evaluate, assess, and again, produce data on these tools is really essential, very key. Well, some of them will become, if proven efficient and impactful, they will become a medical device, and they should be evaluated as such.
Well, thank you.
Well, I would be a devil's advocate. You know, while I think there's a place for AI and technology and all of that, in the Caribbean, we're just not there yet. The biggest thing is reducing that stigma, you know, and it's great to see the developed countries have bigger programs and things are working as they should. But the first thing is getting someone to even say they want help. Yeah. So you need that human element. You need to lead with empathy. You need to speak to them and let them feel it's okay, you know, to have a difference in opinion. It's okay to be going through this. You can get over it. And that's where we are moving. I'm not saying that there isn't a place for AI and it cannot help. But I think first and foremost, we have to you know, get a sense of being comfortable, and this is a safe place, and that's what's important where we are right now, especially with the youths.
Lisa, thank you. I'm glad that we found something we don't all agree on, because I think that's how we make progress. So thank you. A big thank you to the three panelists here. Mark and Jerome, I will ask you to go, and then our Misrak, we have Dr. Mohammed to come back, and Lisa will stay. Lisa. And where's Dion? And Dion is here. So welcome back. We are going to talk now about transformational approaches to mental health, and a special focus on youth, which has come up as a theme through a number of the discussions already this morning. I'm going to pass first to Misrak. Please tell us a bit about yourself. You're a new member of the panel, so tell us why you're here.
Thank you. My name is Misrak. I am the country director for AMREF Health Africa in Ethiopia. I also support our programs in West Africa. So at AMREF, basically our focus is basically the community, our core living, our core essence is how to make sure that we voice the needs and the concern of the community. And the way we do that also is by really engaging communities from the co-creations of our programming, really listening to them, seeing, what are your specific needs, and then developing programs with them based on their needs. So that's basically our way, our major approach. Again, very much focusing on primary healthcare service delivery, as well as social determinants of health, because we feel health is, there's so many other factors that affect health. These are the two pillars that we move forward in our general program implementation.
And give us some of the context from Ethiopia in terms of, put mental health in that context for us, and tell us, how are you thinking about integrating mental health, as you touched on here, within the wider health programming?
So in terms of the aspects of like the different types of work that we do, so we are across all the countries and not just Ethiopia, we're very much engaged in maternal and child health. We're engaged in disease prevention and control. We work around youth development, water, sanitation, and hygiene. So at the end of the day, at the community level, we are engaged in the different sectors, different needs of the communities. And with that specifically, particularly in Ethiopia, we working on youth. We work in areas that are very much affected by conflicts, and in a lot of these areas, mostly women and young people are the most targeted, displaced, etc. So in terms of the mental health space, these are communities that are very much affected. So how we work with in supporting their needs, we do it at different levels. So at the community level is how do we bring the conversation of mental health in the community? So creating like community conversations with our community volunteers and really bringing topics that are very much not discussed at the community level. To be, a starting point, could be through coffee or through other cultural means where communities can very much engage and discuss critical mental health issues, because people are not used to openly discussing about mental health issues. At the community level, again, in schools, how do we really use, teachers into getting young people to open up on their issues, differently with different methodologies. So that's an aspect of our engagement at the community level. And most importantly, particularly in areas, as I said, in conflict, is our frontline workers, our health workers are the most that are, very much affected. And really, yes, when we concentrate on the community, we don't concentrate on the caregivers themselves, because they're the ones that are not only dealing with, the communities, but they themselves are the ones who are dealing with trauma, lost community, like families and friends and members. So how do we support them? So a lot of the content that we've put together for them is, first of all, self-care around, mental health, and also giving them the pathway of, identifying, communities that have needs in mental health, doing some level of counseling themselves as well, and then for cases where they don't have that specific competency, doing the referral. So trying to do like the task sharing, because at the community level, we're not going to have people that are fully trained around mental health. So how do we come up with, different types of packages that support, health workers? Because at the end of the day, they're our main entry point to the communities. And yes, we work around different programs, and we try to use PHC as an entry point to work on mental health. But in order to make it more institutionalized, one of the things we've been doing is, working with different ministries of health, education, ministries of women and social affairs, to see how the different tools that we're putting together, from the training curriculum to the community conversation tools, are co-created again with them at the ministry and regional level, so that it becomes institutionalized, and it's not just on these specific projects that we're working in, but it cuts across, different other programs and different regions that AMREF is not supporting. So those are the different types of, examples that we engage.
Oh, thank you. That's very helpful. And you've actually preempted a question from Slido about healthcare workers, and so it's really important to have that perspective in here. Dr. Mohammed, can I come to you, because you touched earlier on the mental health leadership program in Africa, because I think the role of healthcare professionals and policymakers in deinstitutionalizing mental health care is really crucial. I think interesting to follow on with your thoughts on that.
Yeah, really, thank you so much. Earlier I said we cannot be applying clinical methods to essentially a public health problems on the continent of Africa. So the leadership program is designed to be a continental intervention to address that through a workforce development strategy. What we did is to look at the various areas that we've been discussing here today. First, we need to create mental health leaders that are comfortable enough to speak to the Director General of WHO, the Director General of Africa's presidents about mental health issues and bring up the data to them in a way they will understand. So the first pillar of the leadership program, the Kofi Annan Fellowship, addresses. Thank you. The first pillar of the the first pillar of the program, the Kofi Annan Fellowship, which is the Apex leadership program for public health in Africa, addresses that. Right now, we've graduated 5 fellows. We have 5 fellows in training. What that does is it brings mental health practitioners, health workers, to be with other peers to learn about continental leadership in public health and how they can translate that into other mental health gains. The second one is the field epidemiology training program. And here, we want to equip mental health practitioners, experts, with the public health tools that have made a difference in the other aspects of health. Surveillance, interpretation of surveillance data, evaluation of surveillance, being able to some leadership skills, but very importantly, translating research into policies and strategies. So we have 2 strategies we're using right now: the advanced course that leads to a master's in public health, and the intermediate course targeting different cadre of the health system. We are hoping to introduce a frontline system now that will target what she's talking about, tax shifting and tax sharing at the level of the community. Tie all of this together in our member state and we'll make a difference. The third one is the mental health short course, which is designed to develop a movement of advocates on the continent of Africa for mental health. Whether you are lawyers, whether you are educators, you are lawmakers, and other aspects that complement what we do in this space of mental health. And they can speak to us, speak on our behalf, where we cannot get. Whether it's in the parliament, in making rules on appropriations for budget, they will be there to defend and say, look, these people require more funding, even when we cannot be there. And the last one is a network of people with lived experience and civil society. This is the backbone of the all of society and all of government approach. These are the people that will speak what I cannot say. These are the people that will speak the truth, push the government, and we can be able to have a difference. So that's essentially what the leadership program is. And to talk about what the youth, the aspect of the youth, we are also looking at, because for the health workers, by the time they get to service level, their opinion about mental health is already formed. So we're thinking of doing a pre-service intervention where it will be easier to train doctors, nurses that will not see mental health with stigma, because some of the most stigmatizing colleagues are also those in the health workforce. So if we do a pre-service intervention when they are, quite frankly, still in school, we will be able to change the mindsetting, be able to approach this thing in a much behavioral way than just approaching people who are already in service. Thank you.
Well, thank you. You've taken us back to the people living with these conditions and, in fact, before they live with them. So I want to come back to Dion, because in some countries we know 90% of people living with severe mental health conditions are not receiving care at all. We heard some of those powerful statistics earlier on. How do you, in your view, how do you think we implement the services that they really need? So take us back to those people on the ground.
Well, that's a very tough question, because the factors at the root of the treatment gap, as many of you know, are very multifaceted. It as such requires a very multifaceted set of solutions. And we've already heard some examples with engaging the community in lived experience. We've heard also about AI and e-health and such, about anti-stigma work. I guess I would add on to that campaigns and for example, language guidelines for media sites. And then, of course, also the generating of greater financial resources for improving mental health systems. But I think I guess, harkening back to my own experience as a peer supporter, I would like to focus on one particular solution that I'm very passionate about, which is very much one concern with rethinking how we can deliver care so that it really involves moving away from the centralized hospital-based models, of course where appropriate, that have dominated the mental health care system of many countries for a long time, and moving more so towards community-based and person-centered services that are also integrated into primary health care. Now, of course, that is a lot easier said than done. There are many great examples, like integrated use services. For example, in Canada is one example where they did, in fact, integrate it into primary healthcare. We see Australia as well with Headspace, where they also share the same building as primary healthcare clinicians. But regardless, it is a lot easier said than done. And I guess what I'd like to say to that is that we don't have to start there. We don't have to immediately start at integrating, at immediately both developing community-based mental health care initiatives and then immediately integrating them into primary health care. It's a very long process, and it doesn't mean we can't act already. We can already kind of take the burden off of the mental health care system with, at least in my view, a greater investment into community-based care, with, of course, the long-term goal of also integrating these into primary health care later. And this is something that I imagine a lot of perhaps countries with smaller or relatively smaller budgets allocated for mental health might find very interesting, like an interesting way of testing the waters. Because there's quite a lot of, I guess, community mental health care services out there that maybe aren't immediately or are still working on integrating themselves into primary health care, but still add a lot of benefits. So I would name one example being At Ease, which is a Dutch community mental health care service where they essentially offer walk-in services, walk-in centers, where young people can walk in and they can receive psychological support. And these peer support workers are also then supervised by clinicians, and there is a very strict protocol when it comes to things like crisis situations and how to handle them and how to refer them. And so even though organizations like At Ease are still very much working very hard on integrating into primary health care, it still is very much effective. So we don't have to see this very big daunting goal in front of us and think, oh my God, how are we going to start this, or where can we start? It requires so much investment. We can start with the pre-existing methodologies that are out there. We can start with the pre-existing interventions that are out there and move towards integration as a long-term goal. I think that about sums up what I was thinking about this question.
Oh, thank you. I'm going to go to Lisa, because you bring a real public health lens to this. And so I'm interested in your perspective on what Dion said, but how are you addressing this through your work?
Thanks. So it's a multifaceted approach, and it's a whole of society approach, but I like what he's saying about, you can't do everything. Yeah. And so we know we have to dissect as much as possible. So you have at the highest level the advocacy and the policy and the legislation, and where you have the regional approach that we may say this is needed. And then there is the approach where what is the regional organization saying to the persons on the ground? And I think that's a big focus for us. So in the Caribbean, things that are really working on the ground is the hotlines. Let's start with that. The hotlines are not just you calling, but they're confidential. But you could also do a WhatsApp call. That's big because sometimes the youths don't have, they just don't have the money to make a call. So that's important. And it's 24/7 hotlines. Most of the calls that comes in, sometimes it's after 10 or after 11. So you need to have a person there. So that is working. The other thing that is working is the community-based interventions. So I'm in the Rotary Club. Integrating it into primary care, but into all care is important. So when we go there, we have community-based interventions. One Sunday every month, you go to a different community because you may have, you have poorer communities that may not be able to have access. And we have now added that. So it's not just, food safety and other practices, but, we have a program called Mind Your Mind. And, and protecting your mind is important, and how do you safeguard that? So that's working. My colleague here spoke about FELTEP. We have a field epidemiology and lab training program, and just recently we're adding this as part of the training too, because you're out there, you're teaching people about outbreak investigations, group boots on the ground, but mentally you're always going to be in a stress situation, whether it be a disaster outbreak and so on. The other thing that is really also working is the whole youth program. So regionally, we have a teen mental health influencers program. Right now, we have 12 teens across several Caribbean countries: Bahamas, Barbados, Jamaica, Trinidad, USVI, St. Vincent. But what are they learning? They are learning to become influencers. Sometimes it's easier to hear from somebody who's my peer rather than to hear from an adult. I went through this. I'm at your age. I know what you're feeling. And that program is really, really working. And we do a lot of advocacy to support that, whether it be, hikes and art and other programs that is working. I spoke before on the Barbados Youth Program. That is really interested. And from there, a lot of Caribbean countries are doing the same, where you're speaking about transforming mental health care from just hospital-based to community-based services. So it's promoting public health education, reducing stigma, and also, the youths asking the policymakers to make a decision, as well as countries leading by example. So Barbados, Guyana, Trinidad are now putting mental, well, not only just putting it as part of their service, but putting funding for it. So that has worked. There's a Cayman Island Youth Program, Alex Panton Foundation for the Cayman Islands, similar things, bringing in the youths. The other thing too, so that's youths, it's battered women. That's something, persons, we see that they get very depressed, and so therefore there are targeted programs for them. There's we are promoting employee assistance programs in all public health institutions, all national ministries of health, that you can feel it's okay and it's a confidential thing to go, because we too are faced with all of it. And sometimes I'm very transparent with countries. I says I get stressed and I need a time off. And I think bringing that feeling and that context is important. So ensuring that you have a employee assistance program, but it's not just, but that will deal with that in a confidential manner is some of the things we are doing. And those are the things that are working.
Wow, thank you. Both of you really speak to bringing this to where people are, right, and meeting their needs and meeting them in the moment. Ms. Rack, I'm going to come back to you. I should say AMREF has some fans in the audience. So I'm going to combine two questions here. You've talked about how mental health is an unusual topic in Ethiopia where you're working. So someone's asking here, what's the outcome? How effective actually has been the work that you're doing, and what does that kind of mean on the ground? And then another question about how are you thinking about scaling up the work? What's possible there?
Okay. So our work in the space of mental health, particularly, I'm going to focus on the youth. We've been able to really figure out where to bring the service closer to the community, closer to the youth. So I know you're referring about youth-friendly services, and what we've tried to do is bring youth-friendly services within the PHC. So within the primary healthcare services, having a pretty informal space for young people to come in, to play. They have different games, etc. So it's not necessarily, yes, it's in the health service compound, but it's a space where they would feel, much closer. And then also really training, young health professionals to be more understanding of young people's needs, and also kind of bringing the peer-to-peer work that you're talking about, so that when young ones come into the health facility, they don't feel like they're going to go talk to, someone who knows their parents, etc. So kind of creating a very informal space where they, have, services for counseling, and not just, mental health, but also, sexual and reproductive health needs. So how to somehow cleverly combine those type of services have been very useful. And we also have, outside of, the PHC, we also have youth centers. These are youth centers that are built by government, where young people do gather and come in, and they have a gym, they have like a small cafeteria, they have like a pool table, they have like small training centers. So also including trained counselors, also young counselors, to provide that type of a service. So kind of making it part and parcel of young people's life, not necessarily just labeling it. So those have been like places where we do the peer-to-peer work, and also young people feel comfortable in coming in. Of course, those centers are not throughout the country, so they're only in specific, so there are challenges with that. But those are things that have been very, fruitful, and could also be, very much scalable. We've also, started working on putting together radio programs, because there's a lot of audience on radio, in terms of like type of a podcast where young people would come in and talk about their lives, etc., like kind of a storytelling. And kind of also receiving then, calls on, people like saying, oh my gosh, this story I really relate to. So these are things that are pretty, like different, and can engage more young people to open up, and are also easily, scalable. Now it's a radio program, but, could we put this into, major, like, TikToks or like other social medias that young people are keen into? So those are the things that we're trying to really explore as we move forward.
Well, thank you so much. Our hour and a half together has really flown by. So I'm going to hand to Dion for just a couple of minutes of reflections to wrap us up.
Thank you so much, Beth. I guess this session for me has almost been like seeing my own advocacy journey kind of in front of my eyes, in the sense that we started with a very dire picture of mental health, the fragmentation of mental health financing, like putting the fact that, there's an ever-increasing, mental health is only getting worse, and then on the other side, we have mental health financing not really keeping up with that. So we really started with a very dire picture, and that's kind of what I experienced as well, starting out as a mental health advocate. But then we moved on towards a picture of hope. We saw the power of training youth to help other youth. We saw the power of lived experience, engaging them, the power of engaging the community, the power of anti-stigma work. We saw so many and heard about so many very interesting and very powerful interventions and examples of ways we can help people with mental health issues. And so I guess, just as much as we started on a very dire note, we end on a note of hope.
Well, thank you. Thank you all so much for coming, for sharing your questions with us. I think we have so many of them that we haven't got through, but I really see this as the start of a conversation and not the end. And most of all, a huge thanks to our panelists here and down in the seats here. Thank you very much for such an engaging conversation. Thank you all.